No problem. We can check. Yeah. Hashmi, let me
Yeah,
know
live.
once it's done. Okay.
Yes, yes, yeah. Uday ji, are we live?
We are live.
Yeah, you can
Okay.
check now.
Yeah.
Yes.
So team member, I'll request now you refresh your page and check it again. And please confirm.
Can you share your screen also from there if it is
Yeah.
possible?
Screen उसी share होगा ना? Let me know if you can hear me and you can see me, right? Yeah. Okay. Thanks. Thanks, Vishal. Thanks, Srinivas, for confirmation. इस लैपटॉप में भी ज्वाइन करना पड़ेगा ना जूम? अबे उस कनेक्ट करो फिर। उसको यहाँ से रहेगा। नहीं नहीं, बट कनेक्ट करना पड़ेगा ना उधर पीपीटी। थैंक्स कमल फॉर द कंफर्मेशन। या नहीं ठीक है, एनी वी कैन चेक जस्ट फॉर ड्राई रन। लेट मी नो इफ यू कैन सी माय स्क्रीन। सॉरी, प्रेजेंटेशन, माय बैड। या इज इट विजिबल? आपने कनेक्ट किया क्या लैपटॉप?
नहीं नहीं, it's not visible.
आप सब कनेक्ट करो ना सर। एक्सक्यूज मी, इसको थोड़ा पीछे कर दो, स्क्रीन यहाँ आना है थोड़ा सा अंदर। है ना? भाई आपको कंफर्म मुझे करना पड़ेगा। सर नहीं आया था 5 मिनट। अभी आ रहा है, बट प्रेजेंटेशन तो वहां चलेगा ना? ऑनलाइन जाएगा ना? बट दादा इसको अपने को चेक करना चाहिए पहले। आया था, हाँ? आया था अक्षय। हाँ, ठीक है। जो कैमरा है मैकबुक नहीं आ रहा। मैकबुक में इशू रहता है कई बार, या तो इसको वहां से करना पड़ेगा। हाँ? दादा आप मुझे बताओ, कोई चैनल फिर व्हाट्सएप पे ट्रांसफर करो मैं चेक।
तो हो गया। ये लैपटॉप वाला वो जो आपने भेजा था किस वक्त 107 फ्लाइट वाला है। ये सेट फ्लाइट उसमें इसमें ये सेकंड फ्लाइट क्या होता है।
वो लैपटॉप नहीं काम कर रहा है, इनको चीज रखी हुई
ये लैपटॉप पकड़ाया दिया मैं चेक कर रहा मैडम पहचान हो रहा है।
तो नॉर्मल का लैपटॉप में वो मिक्सर किया था।
हम लोग इसीलिए पहचान हो रहा है कि वो
the group, if you can see the presentation.
Yeah, the slides are visible, but Maheshwar, can
Slides
you?
are visible, Ashmin?
Yes, yes, it is visible,
Okay.
but the view is not complete. If you can adjust the
Sorry?
camera,
What did you say?
the view is not complete. The slide is cut.
दादा दादा सुनाई नहीं दे रहा हो क्या बोल रहे तुम?
Hello?
Yeah, Ashmin, can you please repeat it again?
Yeah, yeah, I'm saying the slides are getting cut. So can you like adjust the camera?
Okay.
अच्छा अच्छा अच्छा
Okay. With the camera, we will show the speaker only, right?
Yes,
But
yes. Speaker and the slides like yesterday, right?
I hope you are able to see the PPT
Yeah, yeah, I'm able to see the
because
PPT,
we are
but
sharing. Okay. And from the camera, we will focus on speaker only.
yeah,
Is
so
that okay?
yeah, both will be from the same location, right? Lucknow.
Same location? Yeah.
Yeah, yeah. So currently I can only see the slide, but that too it is getting cut, is what I'm saying.
Now check.
No, it is still the same.
Okay. आपने जूम लो ज्वाइन किया यहाँ पे शेयर किया स्क्रीन तो कुछ कैमरे से मुझे लगता है हम्म आप बात करो इन बात को देखो चेक करो आप इनसे बात करो एक मिनट अगर जो आ रहा है ही विल हेल्प यू
Okay.
Hello,
Hello?
ma'am. Yes, ma'am. Hello, what's happening? Can you tell me, please, that the PPT is cutting from the sides or the upper sides?
From the sides.
Sides, okay. मैम हम लोग की तरफ से इशू नहीं है. वी हैव नॉट इश्यूज. आप जो है क्या कहते हैं उसको रिजोल्यूशन बढ़ा लीजिए अब लैपटॉप का.
लखनऊ टीम जो पीआईपी आ रहा है ना, उसमें आप जो पीपीटी के ऊपर कैमरा दे रहे हो वो मुझे साइड में दो।
हाँ, मैं साइड में कर देता हूँ उसको।
यस, ये अब पीपीटी के ऊपर आ रहा है, तो पीपीटी फ्रेम के बाहर दे दो कैमरा मुझे।
ओके 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 ओके, मैं इसको छोटा कर देता हूँ।
यस।
ठीक है ठीक।
Ashwin, is that okay now?
Yes, yes.
Okay. Navneet, Vishal, Srinivas, Kamal, can you please confirm? Can you see the screen properly? Srinivas, Vishal. Okay, you can hear me also, right? Great. Yeah. So we'll start sharp at 7:55. Okay.
Okay, okay.
Yeah. All right. Yeah. Thank
Yeah,
you.
thank you.
Okay.
Guests, it is my proud privilege on the behalf of our Ophthalmological Society to welcome one and all. It is going to be indeed an academic feast when I would like to welcome our international speaker, Dr. Kelvin Tao, who has come all the way from Singapore to tell us about PCV. We have a national speaker of eminence, Dr. Manisha Agrawal, who has come from Delhi to tell about the nuances of the disease. And we have our very own Dr. Alay Majumdar, who will be talking about a couple of cases, interesting cases of this disease entity. I would like to request our chairperson for the evening, Professor Sandeep Saxena sir, on the dash. Please come. We have a panel of very eminent ophthalmologists from the city, Dr. Professor Swati Agarwal, Dr. Prabhat Ranjan, Professor Sanjeev Gupta, and Dr. Hem Chandani. To navigate through the evening, we have two very dashing ophthalmologists from the city who will be taking you through to the evening during the academic evening, which is Dr. Samarth Agarwal and Dr. Alok Maheshwari. So without further ado, I welcome Dr. Samarth to take over. Thank you.
Good evening, everyone. Before we start, can we please have Dr. Kelvin sitting in front? Please come forward, sir. And ma'am, Manisha ma'am. So it's my absolute honor to introduce our guest today, Dr. Kelvin. He's a world-class eye specialist and surgeon from Singapore with over 15 years of experience. He's a leading expert in treating complex retinal detachments, retinal conditions in both adults and children. He's earned his medical degree from London and a PhD from Sydney Eye Hospital, Australia. He's completed 2 prestigious fellowships in medical retina from the Singapore National Eye Centre and Sydney Eye Hospital. This extensive global exposure allowed him to pioneer cutting-edge eye treatments, including Singapore's very first advanced gene and dry AMD therapies. He's published over 150 medical papers and won major awards for his research. He has also helped lead Singapore's national eye screening programs and teaches the next generation of doctors as a university professor. Today, he treats patients at the Advanced Eye Clinic and Surgery and Mount Elizabeth Hospital. Please give him a warm welcome, all of you. I think we still have a couple of minutes before we actually start your talk, so you can please have a seat till then, and we'll just call you when because we are connecting nationally for the other cities, so we will just wait for some time. Before that, I think we can introduce Dr. Manisha ma'am as well. Alok sir.
Good evening, all. And we also welcome our second speaker, very eminent personality of the national level, Dr. Manisha Agrawal. She is Director Vitreoretinal Services at Stroff Charitable Eye Hospital. She has over 2 decades of experience in vitreoretina and uveitis and alumnus of Shankar Nethralaya, Chennai. Dr. Agrawal has done her fellowship in vitreoretina and clinical research. Her experience in the spread over is wide spectrum of subspecialty of the eye care, which includes managing all patients of the medical retina, including diabetic retinopathy and ARMD. She is the Secretary of Uveitis Society of India and Honorable General Secretary of VRSI. She has made more than 200 presentations at various national conferences and participated in many international conferences. To her credit, she has co-authored many papers and the book chapters. We welcome ma'am. We have third speaker, Dr. Alay Majumdar from Lucknow. He is a vitreoretinal consultant at the Chandra Super Specialty Eye Hospital and very prominent personality of the Lucknow, and we welcome him.
So we still have 10 minutes before we start because I think we have to connect at 8 o'clock. So before we start, I'll just go slightly off topic since we have Dr. Kelvin here. I was reading about it and I realized that you were the first one to give a injection for geographic atrophy in October 24. So it's been almost 1.5 years, and have you had how was the follow-up like, and what do you have to say about it? Please enlighten us.
Yeah, so I had the opportunity to give eye survey in a patient. In fact, now I've got 5 patients on anti-complement. It's it's almost exactly opposite to what you would tell a patient with neovascular AMD. So here you're telling the patients you can wait a little while, you see how it progresses, and if there's growth and there's progression towards the fovea, then it's worthwhile treating. So it's a little bit different, right? So with neovascular AMD, you say, oh, we have to treat you now. Early treatment is important to preserve your vision, improve your vision. Whereas here we're talking about preserving already good vision. So I've been very selective with my cases as well. So I only treat only eye patients. So if they had lost vision on the other side, and this eye is at risk with geographic atrophy, I treat also only with features that are fast growing. So you have to have the hyper reflective rim, you have a fairly large lesion, and I have to see most important that there's progression. So I follow them for at least 6 months before I start treatment, and they have to have some growth towards the fovea before I start. And it's worked out quite well. So for all of them, actually, the growth rate has slowed down, because it's nice that if you have the progression rate from before, 6 months before, you can see how fast that's growing. And then when you start treatment, you can show them actually, your growth is slowing down. So on all fronts, it's a safe treatment. It's unfortunately very, very costly at the moment, because I have to fly in from the US, and the patients have to pay for 3 injections at a time. So it's quite costly. What else?
How much
I
is
do
the
it a bit.
patient paying for it in Singapore? Just out of curiosity.
So they pay 5,000 Singapore per injection, just for the medication itself.
Okay.
I do a bit differently. I don't do every month. So the trials have talked about every month treatment. I start them every 8 weeks. And then if they are stable at 8 weeks, I keep them on 8 weeks. If they are growing a little bit faster, I pull them back. So it's again completely different from what we think about with wet AMD, right? Wet AMD, talk about loading every month and then slowly extending. Here I go for 2 months, and if things are okay, I keep them at 2 months. If things are progressing, then I bring them back. So it's
And how are you monitoring the progression for these patients? Is it on FAF always, or?
yeah, so that's tricky. So I have everything at my disposal. I have FAF, I have OCT, I have on-fast OCT, I have a subscription to an AI that can tell me about the size of the RPE loss on OCT. So I use all of this to try to track that progression. And with some of these tools, it's very nice. You can see the RPE loss, the line, the curve flattening out. So that's extremely useful. But I think if you have to have only one modality, I think it's going to be FAF if you want to track these patients.
So if cost was not a constraint, I think you would be using it in many more patients in your practice. Would you say that?
Yes and no. So my practice now being a little bit private practice, these patients they come already, with the idea that there's going to be a costly treatment because it's new, and they're prepared to pay for it already. Often it's because they lost one eye to dry AMD, so they know that that's going to happen in the other eye. They're more compliant to the treatment.
Thank you so much. I think moving on from dry AMD to wet AMD, today's topic. Can we have the buyer team set up the link, and we just got 5 minutes to go. Any comments, questions till then? We've got another 4 minutes to spare. We'll go to someone who always has a question.
Uh, good evening and welcome here, Kelvin. Meeting you after a very long time. Last we met in probably the AIUS last when you were here, right? Right. So, hello, Manisha. Again, welcome to Lucknow. How are you using your aflibercept? I don't think you are using brolucizumab there in Singapore. Absolutely not, right? So, what are your usage of aflibercept vis-a-vis faricimab?
So I don't have any more 2 mg. So I've converted all the 2 mg to 8 mg. So all my existing patients on 2 mg have been converted to 8 mg. So, and I've got quite a large pool of existing 2 mg patients. I do use faricimab as well. So the proportion probably is about 60% aflibercept, 40% faricimab in that ratio.
So you have been using aflibercept 8 mg for how much time have you been using as yet?
I got my first 8 mg last March. So about a year.
So about a year,
about a year. Maybe a bit more than a year.
So how is your 2 mg vis-a-vis 8 mg regarding the impact and the durability?
So with the 8 mg, really, you're getting a lot faster efficacy. So you're drying faster. I feel that that's actually the case. I can't really speak to durability because I feel like I don't have long enough data. But at least the ones that are treating have managed to go out to a large proportion managed to go out to 4 months or more. So it gives a lot of confidence when I start them on 8 to tell them that, you know, you're on track for 3 injections a year or you're on track for 2 injections a year. And that makes the conversation very different from previously.
Okay. So your 8 mg has reduced the number of injections in a year and has also increased your first impact.
Yeah.
So you are using your 8 mg both in treatment naive patients or recalcitrants or switchover patients, all of them?
So I use them in both. I will use 8 mg always for PCV.
Okay.
So that's
are you using aflibercept or 8 mg aflibercept only on PCV, that is type 1 CNVMs, or also in type 2 and type 3 CNVMs?
So if it's a PCV, I will use aflibercept.
Definitely.
And then the other types, it can be faricimab, it can be aflibercept. Yeah.
So are you using ranibizumab for anything?
Not anymore.
Not anymore.
We use it in the public hospitals a lot, ranibizumab, but because of the reason, again, this is about pricing, right? So recently in Singapore, the 2 mg price has come down to the same as ranibizumab. So I believe that market will go to aflibercept as well.
Okay. Now, in Singapore,
Dr. Aloy, sorry to interrupt you. I think we are up for his talk.
Thank you so much. We continue.
Dr. Kelvin, you can please join us on stage and we'll start right away with your presentation.
Thank you very much. Thank you very much. Good evening, everybody. Thank you for the invite to first time in Lucknow, many times in India, but first time in Lucknow. And very happy to be here. So this evening, I'm going to talk about PCV. We're going to talk a little bit about a quick overview on the prevalence. We're going to talk a bit about diagnosis, essentially some of the work that we did to try and make PCV, the diagnosis of PCV a little bit more accessible. Treatment guidelines, published some treatment guidelines in 2025 with APVRS, as well as some of the trials and evidence using aflibercept in PCV, and a little bit on some of the future therapies. So we know that PCV is very prevalent in our part of the world, 60, maybe even higher than that, prevalence of neovascular AMD subtypes. And in Caucasians, about 10 to 30%, possibly because they don't do enough ICGA. Do we do ICGA here in Lucknow? Yes, yeah, okay, good. So we know that ICGA is the gold standard for diagnosing PCV, well established in Everest, and a lot of work from our Japanese colleagues. But ICGA is time consuming, it's invasive. I like that we have hands raised, that people still do ICGA angiography here, but in Singapore, when I ask the same question, many are shy to put their hands up, or they don't because they really just have an OCT machine. And here are some examples of what PCV looks like on ICG. I'm going to play this video here. Of course, we have this very typical, what we call pulsatile polyp. So that polyp is pulsating away if you have the opportunity to have video ICG angiography. So while those pictures are very obvious, you see the very large polypoidal lesions. The question was, can we use alternative imaging modality to diagnose PCV without ICGA, without having a patient go through the procedure itself? And so we did this work back in 2020. It was an international effort to try and make the diagnosis of PCV a little bit more accessible. The idea wasn't that we could replace ICGA, but was to give ophthalmologists a tool to suspect that there was a polypoidal lesion versus what we call a typical neovascular AMD lesion. And so we looked through all the literature that was available at that time, and we took the features together and we ranked them essentially of what would give the most accurate differentiating ability of PCV versus non-PCV. So the ones in green are what we call the major criteria. We had the minor criteria in orange, and really the ones in red didn't make any difference. So from this study, we concluded that if you take any of the top, so if you take the top 3 features and any of the minor features, you actually have a very good ability to discriminate between PCV and non-PCV eyes. And if you look closely at those top 3 features, really they're all OCT-based features. So cross-sectional, you have the sub-RPE ring, sharp peak PED. And if you flip your OCTs and you look top-down, you see an on-fast OCT complex elevation, and that's that middle picture there. And I will tell you that on most, if not all of your OCT platforms, your ability to get this view is there. So you need to just play with your settings and you can get that on-fast OCT view. Oftentimes, you just need to do a denser scan to get these images. So I think the best way to look at some of these features is look at some examples. So here you can see on cross-sectional OCT, you can see peak PEDs, you can see sub-RPE ring lesions. And on the on-fast OCT, this is looking top-down, you can see this very irregular shaped complex RPE elevation. And that essentially highlights the branching vascular network as well as the polypoidal lesion from an on-fast view. So here is the ICG of this patient, and you can see the polyp lesion there very clearly. Let's look at another example. So here you have, again, the sub-RPE ring. You have a double layer sign as well, and we all know that the branching vascular network sits in that double layer sign. You have a little peak PEDs all along the way. And again, on fast OCT, you see the complex RPE elevation. And I show you again the ICG for this patient. Very clearly, the polyps are there. Let's look at the ICG of this particular eye. And here you can see hypersenescence or hyperfluorescent spot. And one could be forgiven to mistake this for a polypoidal lesion. But if you look across your OCT, you don't find any of these features. So no sharp PED, no ring lesion. And of course, this is a type 3 or a RAP lesion, which can show up as a hyperfluorescent spot on ICGA. So not only do these features give you the ability to pick up the PCV lesions, it also gives you the ability to differentiate and say, hey, hang on, perhaps this is not exactly a PCV lesion itself. It could be a type 3. So let's move on to OCTA. Really nice technology that's come a long way. And if you look at this particular paper here, all the way back in 2014, this group tried to differentiate PCV from typical neovascular AMD using OCTA. Now, if you notice here, the sensitivity for on-fast OCTA was pretty poor. They also used the on-fast OCT to try to improve their accuracy. But if you look at that, the view from the top down, so we're very used to seeing OCTA from an on-fast view. So you get those beautiful networks, but sometimes those beautiful networks don't actually tell you that there's a polyp in the eye, or it's more difficult to pick up. We took this work a little bit further. So 5 years later, in 2019, our group then published using OCTA. But now, instead of looking at it on fast, we draw attention to the cross-sectional OCTA. And so here you see flow signal within the sharp peak PAD. And that really tells us that there's a polypoidal lesion in that peak PAD itself. So with the use of cross-sectional OCTA, on-fast OCTA to pick up the branching vascular network, you see that the accuracy, the sensitivity, and specificity really goes up as compared to just using that on-fast view that we're so used to. So now we fast forward to 2025, 2026. So this is my OCTA platform in my clinic. It's a NIDAC RS1. It's a prototype machine, so it has little tweaks to help me visualize the neovascular network better. And likewise, you look at the cross-sectional OCTA, you can see the flow signal where the polyp is, and that cross there really corresponds to where the polypoidal lesion is, and the rest of it really is a branching vascular network. So that's the ICG there for that patient. And we took this work a little bit further with the Plex Elite OCTA platform. Here, what we did was we took multiple OCTA scans, we registered them, we put them together, and then we applied a three-dimensional algorithm to see whether we could visualize the polypoidal lesions itself in 3D. And these are some of the images that we came up with. So you can see that polypoidal lesion sitting nicely above the branching vascular network, giving us a appreciation of the morphology of the lesion itself. You could overlay as well here in green the RPE layer, so you can see the RPE draping over the polyp lesion. So again, telling us what we already know, but visualizing it in a different way, that these polyps sit under the RPE. And the bit in blue actually was the ring lesion that I got my fellow and myself to painstakingly segment. And the ring lesion itself, as you can see, actually sits inside this coil of vessels, which is the polyp lesion itself. So that ring is not actually filling up with flow signal as we might have thought before. So that's some of the ways we can diagnose PCV. So ICGA, of course, still gold standard, but with OCT, just your regular cross-sectional OCT and on-fast OCT, you're able to have an educated guess on whether or not your eye has PCV or not PCV. Let's move into treatment. So in 2025, APVRS published some guidelines on diagnosing and treating PCV. So here they very kindly incorporated our OCT criteria as well for a suspicion of PCV if you didn't have ICGA. Of course, if it's large submacular hemorrhage, you want to do some surgery, pneumatic displacement. If you had active extrafoveal polypoidal lesions, you could consider focal laser, all very reasonable. But essentially, initial treatment, what they highlighted was that you can use anti-VEGF monotherapy, and it's not wrong, right? And this was based on the history where many thought that PCV could only be treated with combination anti-VEGF and photodynamic therapy, which I understand that is not available widely here in India. Of course, after treating with anti-VEGF monotherapy or combination therapy, you need to monitor response. And they had some emphasis on regression of the polyps, stability of subretinal fluid. And then, of course, you go into a treat and extend regimen. And that was, again, based on disease activity. So really, my first choice for PCV today is monotherapy. So monotherapy with anti-VEGF. I mentioned it just now, I use aflibercept. And the reason I use aflibercept for PCV is because it has probably the longest lasting body of evidence to treat this particular subtype of neovascular AMD. We've got lots of other agents that are there, and I believe they're all effective. But if you look at the body of evidence for PCV treatment, really aflibercept has done multiple phase 4 trials, Planet, Altair. They've looked in subgroups of the phase 3, really having a very good body of evidence for the treatment of PCV as a monotherapy. Vision to me still remains the most important outcome for patients because all our patients want to see. They don't really care whether there's fluid or not in their eye or the polyp is open. They care whether they can see. So vision remains most important. But of course, there are other anatomical outcomes. And in PCV, what's different, of course, is the polypoidal lesion itself, right? Because we have neovascular membrane and an added polypoidal lesion. So one of the anatomical markers will be complete polypoidal regression, reduction in the area, and of course, inactivity. So you hear a lot about polypoidal lesion inactivity in the upcoming results in many of the trials that are coming up. I'll go into that a little bit later. But if we look at some of the trial evidence, so here you see in View 2 and of course in Planet, excellent vision gains in patients with PCV. In Planet, of course, I mean, to me, Planet was really a trial that was looking at aflibercept as a monotherapy, and you could have rescue PDT if you needed it, but it established very good evidence for its effectiveness in this subtype. So more than 80% showed polyp inactivation and gain of more than 10 letters. And again, this concept of polyp inactivation, and I'll talk about that a bit later. Again, across all the real-world evidence, you can see excellent vision gain as well as, and here we're talking about complete polypoidal lesion regression. And this rate really varies between about 40%. I know a lot of my Japanese colleagues are reporting closure rates of over 70% with aflibercept. Remember in Planet, after the fixed treatments and rescue PDT, in year 2, patients were able to then begin to start having a treat and extend. And with treat and extend, you could really start to see the reduction in number of injections necessary to achieve good vision as well. So not only could aflibercept quieten down the polypoidal lesions, it could also do it very efficiently with fewer number of injections. We are now 8 years, I think, past Planet. And we had the opportunity to publish 6-year outcomes of the Planet study. So I wasn't biased. We also published the 6-year outcomes of Everest study. So that these 2 papers out, I think they came out last year. And so essentially what we did was we recalled patients from the 2 studies and we looked at their outcomes after 6 years. And in the Planet study, you can see that more than half the patient, about half the patients had more than 70 letters. And very respectable number gained 10 to 15 letters even at 6 years. And what was pretty interesting was that polyp lesion closure rate improved from 30 to 70%. Number of injections, however, is very low. And so we wanted really to dig in and see if you had treated these patients appropriately, whether they would do better. And so we looked particularly at the countries that were reimbursed. So patients didn't have to pay out of pocket, which meant that hopefully it took the financial burden out of the equation. You can see that the number of injections really go up from 2 to 9. And really with more injections and appropriate treatment, these patients gain vision and central subfield thickness was significantly lower. So really, driving home the point that you need to keep on top of these patients and treat them appropriately for a long period of time. So I'm going to show you some examples. I dug up some of my old Planet patients and a little bit of their long follow-up as well. So in this patient 1 from Planet was in the monotherapy. So sham PDT was given to this patient. 9 Eylea 1 sham PDT, and during the course of the trial gained 20 letters, so 615 to 66 vision. You can see the anatomy as well, improving very nicely. Here's another patient from monotherapy, 630 vision, 8 Eylea, and in this patient as well, excellent gains, 28 letters. Again, that anatomy showing that the polyp has closed off, and very nice OCT there with no fluid. Of course, then, moving forwards after the Planet study, we could do a treat and extend. So I'm going to show you 2 patients that I treat and extend with 2 different strategies. So this is traditional treat and extend with 2 weekly increments. So very standard, with no fluid, patient gets extended every 2 weeks. And this patient was very compliant, was able to go all the way up to year 3 and go all the way up to a 16-week interval on 2 milligram. So you can do even very long follow-ups with 2 milligram of aflibercept. Here is one with extended interval. So here I'm taking a 4-week step. So 4 weeks 8 weeks, 16 weeks. And so in this particular patient going up to 1 year, you can see 7 injections, again, very respectable, 64 letters at the end of the treatment. So I said I'll come back to this idea of polyp inactivation. So active polyp or inactive polyp essentially is the presence of a polyp on ICG, and in this case, an inactive polyp without the presence of fluid on OCT. Yeah. So polyp is there on ICG, but no fluid as an inactive polyp. If the polyp is there with fluid, of course, it's an active polyp. So this is one of the anatomical outcomes you'll hear a lot about in trials like Sarween or post-hoc analysis of PULSAR. This concept of inactive polypoidal lesions. So in this particular case here, baseline, you have the polyp lesion, you got some intraretinal fluid. At month 3, you had the polyp lesion on ICG, but no fluid. So this is an inactive polyp. What would you do? Treat and extend, go to 8 weekly injections, PDT. In this particular case, I still do PDT. I do a lot of PDT. And in this case here, I did a PDT for the patient, and you can see the polyp lesion closing up very nicely. But here's another thing that you could potentially try. So we did a little trial of a treat and extend, a personalized treat and extend regimen in PCV. Essentially, you would give 3 loading doses, and at month 3, you repeat an ICG. If the polyp was still open, you give another 3 doses, so a total of 6 aflibercept 2 milligram, and we looked at those outcomes. And I'm going to show you essentially the numbers that had complete polyp closure. So if you did follow this treatment regimen, you would get 55, almost 60% closure rate with applying this particular treatment. So not having to give 6, but having that extra ICG at after the first loading, and if it was still open, giving another 3 would give you 55% of eyes closed polyps. Right. So this is essentially what happened to this patient here. So it is an inactive polyp. It's still there on ICG at month 3, and with additional 3 aflibercept, you can see that polyp's gone, and in fact that OCT anatomy looking really, really nice. So why treat and extend? Why not stop? And in this era of you call it 2nd or 3rd generation anti-VEGF, we're talking about very long extensions. We're talking about eyes going 16, 20, 24 week treatment. So why not stop treatment? So remember, I showed you some of those planet patients, and I showed you really up to the point where they ended the study. So remember, first patient had 20 letters, second patient 28 letters. Got some other patient 3 and 4 here with good gains after the planet study. Let's look at patient 1 and his long-term follow-up. So after exit, 6/9 vision, patient refused treatment, and this is something we see. Unfortunately, patients do well, and then they say, look, doctor, you cured me. Thank you very much. I'm not coming back anymore. But a year later, he worsened and had to give him some PDT at this point. And essentially, 4 years after the end of Planet, because of his infrequent follow-up and needing repeated PDTs, he developed a big scar, essentially. And vision was affected, count fingers. So from the end of Planet at 6/9 vision, poor compliance, didn't want to come back, came back a little bit too late, developed the scar, counting fingers 4 years later. Let's look at Planet patient 2. Remember, this guy gained 28 letters on monotherapy, no rescue PDT. Exited again with 7.5 vision, declined Planet follow-up study. And essentially, again, lost the follow-up, but again, represented in emergency with a very large submacular hemorrhage down to counting fingers. He was a little bit luckier because with 6 aflibercept injections, he managed to get that vision back to 6/12 and hemorrhage cleared. And patient 3 here. So you can see here, in this particular patient had active rescue PDT during the trial itself. Exited with 6/9 vision. And in this particular case, patient was actually fairly compliant. So came back, managed to extend out to a 10-week interval, and is continuously being treated at a reasonably long interval, I would say 2 to 3 injections a year, maintaining that good vision. Another patient here, you can see, again, very compliant with his treatment, was able then to go out to a nice treat and extend. And for him, I kept him on a 12-week maintenance, so every 3 months, again, keeping that entire lesion under good control. So it probably is worthwhile to address, the recent evidence coming up about PCV. Again, you'll hear, I'm sure, a lot about the Salween study. And it's probably not reasonable or unfair to compare what is happening with the Salween patients versus what the results were for Planet, or for that matter, I'm sure you will hear the subgroup analysis in Pulsar for 8 milligram. Essentially, it's because these are different trials. They've done different things. I participated in both. I participated in all three. In fact, I was reading center for Salween, so that 77% confirmed diagnosed PCV was my fault. In Planet, you had 95% confirmed PCV, but in Salween, it was a very deliberate move to make sure that we had a very clean group of PCV patients. So we wanted to be very sure with at least one of the analysis that these were confirmed diagnosed PCV, and hence that little bit lower rate. As you can see, the treatment regimens are different. With aflibercept, traditionally, it's always been 3 loading doses. With faricimab, it's been 4. And as well as some baseline differences between the two trials. So, they report a closure rate of 60% in Salween. It is a high number, but bear in mind some of these features and differences in the trials, right? The patients might be starting with a little bit better vision. Remember, they had 4 loading doses, which might have contributed to that good closure rate as well. If you look at some of the evidence comparing aflibercept and faricimab in PCV, so this was done by our Japanese colleagues, here they showed that after the first 3 injections, there was actually a significant difference between those treated with aflibercept versus faricimab in terms of vision, as well as anatomy. So I'm going to show you a series of cases. And essentially, these were responses we saw when we switched patients out of aflibercept 2 milligram when it first came. So, as a new drug comes, we're all very excited to use it. And we were very excited when faricimab came to the market, and we thought we would try and switch some of the patients maybe that were a little bit more difficult to treat from aflibercept 2 milligram or other agents to faricimab. So in this particular case here, it wasn't aflibercept actually. This gentleman was treated with 3 ranibizumab injections every 4 weeks. This was his OCT after 3 monthly ranibizumab injections. You could still see the presence of some subretinal fluid, so a little bit active, not terrible. After giving 2 faricimab injections, this is what he looks like. So I put the baseline scan up there, and I'll put the after 2 faricimab injections up here. You can see that there is this large PED that's developed inferior, right? And although the subretinal fluid has gone away, it's replaced a little bit with a subretinal hyperreflective material, or SHREM. And SHREM to me I don't like SHREM. SHREM is a sign of disease activity. Increasing PED size, especially in the presence of PCV, is increasing activity because polyps are going to leak and it's going to accumulate under that RPE. So paradoxical response with the use of faricimab, after previous treatment. And because of that, we switched the patient back to aflibercept injections, 2 milligram aflibercept injections. After 2 injections, you can see that settled down actually very nicely. Not just one case, we did notice this paradoxical response in some cases. So as you can see here, these 2 eyes over 10 injections, and these were with 2 milligram. After switching to faricimab, giving it a good go. So we have 3 injections, 4 injections in the bottom, 3 on the top, 4 on the bottom. You can see this paradoxical response again. And what's interesting is that the disease activity seems to be appearing at a little bit of a different spot. And then because of this increasing activity, we were not comfortable to continue them on faricimab. We switched them back to 2 milligram, and that seemed to settle down the activity in most of these eyes. I'll show you this one last case. So this is a 74-year-old gentleman. So this wasn't a PCV. This was a type 1 CNV, previously treated with aflibercept 2 milligram. Looked very nice and quiet. I remember wanting to switch him because I was thinking maybe with the newer agents, I could get a better durability. I could extend them out further. So essentially, it didn't pan out. I still had to give him 4 weekly injections, and this is what happened. So after 2 milligram, the neovascular network actually looked pretty nice, just left with a matured trunk. But after faricimab, 4 weeks after the faricimab, you can see that neovascularization, that network growing a lot bigger. Not a lot happening on OCT, so it's just a little sliver of fluid, but definitely an increase in that network on OCTA. And of course, at this point, I had my hands on some 8 milligram, and with 8 milligram, it shrunk down that neovascular network from what it looked like in the middle. So back to my previous point, I think aflibercept has probably the longest and largest base of good evidence, both in terms of clinical trial, real-world studies, and my own clinical experience, especially in treating PCV. Is my first line for PCV patients because of these reasons and because of my own experience as well. It has been extremely safe. I haven't seen one IOI with aflibercept 2 milligram, and that's in comparison to a handful of IOI that's seen in faricimab. And I have no experience with brolucizumab, so you guys can tell me better. But I understand that there is some safety issues with that. I've used the aflibercept 8 milligram now for about a year and a half, and again, very, very safe. So that one I haven't seen any IOI, but not a long period of time just yet. So I touched a little bit on new therapy since we're going a little bit into 8 milligrams. So I think the future scope and the buzzword is about durability. So you'll hear a lot about TKIs, you hear a lot about gene therapy, and of course, things like 8 milligram, which I would still consider new-ish. It's not in India yet, and hopefully you'll get it this year. This slide is very busy, but this just gives you an idea of what's in the pipeline. So the multitude of different molecules that are coming up to address durability and efficacy in this disease. I'm going to show you some of my 8 milligram cases. So previously treated PCV started with 2 milligram, 3 monthly loading doses. So this is baseline image. You can see post-loading, patient did extremely well. So again, not surprising, 2 milligram, polyps closed, OCT anatomy looks very nice. Most people would then, at this point, extend the patient, and exactly what I did. I extended this patient to 8 weeks. At an 8-week mark, when the patient came back, I noticed a new PED inferior, and I repeated an ICGA. And if you look at the baseline image, you see the polypoidal lesion much more foveal, and this one's coming out. So it's a new polypoidal lesion that's appearing. And the patient was not happy when I suggested to cut the interval back to 4 weeks. She said, "Look, doctor, my vision's good. Why are you trying to drop the interval back to 4 weeks again?" And so at this point in time, I got my hands on some 8 milligram. And as you can see, after 8 milligram at an 8-week interval, that disease control is excellent. And this patient went on to get further extensions. This is perhaps my most favorite case for 8 milligram because this was my first 8 milligram case. So very hard to treat polypoidal lesions. So you can see 6, I think it was more than 6 aflibercept injections. Polypoidal lesion, a very large PED with a sliver of SRF. So, that large PED wasn't changing even after multiple injections, and that polyp lesion was still present on ICGA. And because this patient was my first 8 milligram patient, I told him, you're getting it first, possibly first PCV in Asia, possibly in the world. You need to come back every month, and every month I'm going to do an ICGA for you. And he said, okay, I'll come back and get ICG every month. So after the first 8 milligram, this is what he looked like. PDs come down very nicely. And over second, third, you can see the polypoidal lesion on ICG getting smaller. Vision is improving. PED is getting smaller as well. And finally, after the fourth aflibercept 8 milligram, you can see the polypoidal lesion itself finally closing off. And again, the anatomy on OCT looks very, very nice compared to what he was before having all those injections. And he's actually done very, very well. He's gone on to a long interval now. I think he's about 4 or 5 months between each injection. So that's my presentation this evening. I'm happy to take any questions. Thank you very much.
Thank you, Dr. Kelvin. Please have a seat next to the chairperson. We'll just have a few questions from the audience if there are anything from the panelists before we move on. Any comments from the chairperson, sir?
It's a very nice talk. And what is the mechanism of closure of these polyps, and how do you feel that that this 8 milligram might be superior to the 2 milligram ones?
So with PCV, I think it's interesting because you have two parts of the lesion. You have the branching vascular network and you have the polypoidal lesion. I think that the branching vascular network is a much more mature net, and the polypoidal lesion is much more immature or younger. And because these vessels are smaller, they're sprouting vessels, then they're much more sensitive to VEGF or anti-VEGF. And so with a higher dose, like 8 milligram, actually will help to close those new vessels down much better, much faster in that sense. Yeah.
So, Dr. Kelvin, we did see a few cases where you talked about switching from 2 milligrams of aflibercept to Vabysmo. So, what was the reason behind that switch? Was it inadequate response?
So, variety of reasons. One was actually the curiosity of trying a new drug, and in many of them was about trying to extend the durability, the intervals. And because of the promise of having a drug that could go 16 weeks, we then did a lot of those switches. So you switch for two reasons. One is because it's not responding well, and then second is because you want to get a longer interval. So really a mix 50-50 of those patients.
So apparently faricimab seemed to disappoint you in those cases. So did you come back to Eylea 2 milligrams, or did you go back to move forward to 8 milligrams, or what was the way out?
So of course, being a Bayer talk, I show you the
the good part of
good part.
Yeah.
But I mean, in reality, you will get patients with good response with faricimab, and I'm sure everybody here has this experience as well. But likewise, I'm sure everybody here also has that same experience I've had. If you treated enough or switched enough, that you have this paradoxical response. I mean, I'll tell you, back in the day when we only had Avastin and ranibizumab and aflibercept came to market, to me, it was a big wow factor, right? It was a drug that quieted everything down very quickly. When faricimab came to the market, then I didn't get that same wow, because there were some of these cases that didn't seem to respond so well, and we couldn't yet put our finger on why.
Because we had a lot of wow factor and brolucizumab in India, but then it had its own set of problems. So I think that's another challenge with the newer drugs which come in. So talking about Vabysmo, I mean, faricimab versus aflibercept. So in your mind, how's the safety profile of both those drugs in your country?
So I think they're both extremely safe drugs. This is not a session about faricimab versus aflibercept, but I think for both drugs, they are just as safe. The reason why I see maybe more IOI in faricimab is just because these could be eyes that are a little bit more sensitive. They could be eyes that are a little bit more difficult to treat, and perhaps that might contribute a little bit to having that a bit more sensitive to inflammation.
So if we talk about the Indian context, so even as of now, if we look at the anti-VEGF numbers, we still have the maximum number of probably bevacizumab or ranibizumab in the usage pattern here. So before you had access to, let's say, aflibercept, and I mean, PCV has always been around for so many years, and aflibercept and these molecules are relatively new here. So given a choice, if someone actually cannot go forward with one of the newer drugs I mean, it's very pertinent to the Indian context. So if we do not have access to the newer drugs, how was your experience with ranibizumab before these things came in?
So ranibizumab is a good drug, right? In fact, I think any anti-VEGF is a great drug for AMD and PCV. I would say that back in the point before aflibercept, or patients that couldn't afford aflibercept, we would dose a little bit more frequently, maybe down to 3 weeks, to try to get on top of things. In reality, what we would do is we do PDT But again, in the Indian context, because
The
you
diet
don't
is
have,
available here in
you
India,
don't
so
have
yes.
you lack the PDT. So, shortening that interval is one option. I do know of some colleagues, again, this is completely off-label, but they add a little bit of steroid. But shortening that interval was generally my first line.
Because if we talk about more number of injections of ranibizumab vis-a-vis aflibercept, then I think the cost benefit might get lost in the long run if you actually look at the number of injections of ranibizumab which a patient will need in his lifetime, as compared to maybe just 2 injections a year or 3 injections a year for aflibercept. So I think the cost benefit gets skewed in that way of
That's absolutely right. But when you try and project costs like that for patients, they only think about here and now and what they're going to have to pay. So sometimes that cost benefit calculation doesn't play out well for the patients. What I find actually more useful is to tell them that, look, if you get on these newer agents, we're talking about 2 or 3 injections a year versus the older agents that might be 6, even 8 injections a year. And when you put that into numbers for them, then they start to understand, oh, you know what, I don't have to see you so often actually.
And how do you counsel the patients for patients? So, I mean, patience is a big factor here, because when we see little response and the patient is not seeing better, it is very difficult to keep him on the therapy. He tends to drop out. And that's a challenge which we face every day. So I'm sure it's the same challenge with you as well.
So, it's if honestly, if there's no good response or if the response starts to slip even after one injection, I have a low threshold for switching at the moment. And it's
So
because
when you say switch to 8 mg or switch to another molecule?
so tend to switch to 8 mg because I really value the high anti-VEGF effects. My personal take on this is that these diseases are all VEGF driven, right? So there's a very, very strong VEGF drive going on. And if we can suppress VEGF enough, you're getting a good response. So in these particular patients, what I tend to do is I tend to switch them, but I tend to see them a lot earlier. So I see them maybe a week or two after the injection. And there you're looking for response. So it really tells the patient as well, look, it's not that you're not responding to the drug. You are responding. It's you just maybe you need a shorter interval. And that really tells the patient that, the drug is working, doctor's doing the right thing. And okay, so maybe we can say if you go another 2 weeks to a month, a little bit of fluid, we can tolerate that, right? But as long as I see that they have a response, I'm happy, patient is happy.
I think counseling has a major role to play in any of these long-term chronic therapies. And moving on to, so in India, we recently had a lot of, biosimilar coming in for aflibercept, and there has been a mixed response all over the country. So we in general have seen good effect, but then there have been equal reports of having adverse events here and there. And the jury is still not out on the actual reasons behind it. Some people say the company says it's because of cold chain, for example, but we're still not sure of that. So interestingly, an Indian company, Biocon, is about to, it's got approval in Singapore for aflibercept biosimilar. So since you're the first mover for all these things, so did you have any experience with the Biocon
I don't
aflibercept in Singapore?
I don't use biosimilars. I think the concept of biosimilar for monoclonal antibodies are extremely tricky because a lot of it comes down to manufacturing, and it is your facility, your GMP facility, your cold chain, the way the protein is constructed. It's very different from a generic drug, which is chemical, which you can copy exactly the same. With biosimilars, there's a lot of engineering that goes behind creating these monoclonals. And I'm not entirely sure some of these companies can do it to the same kind of quality. That's the worry. Oh, I could be wrong. Next time in India, I could be talking about biosimilars.
I think it will take some time before we have a surety on that. Any comments from Dr. Manisha, ma'am? Can we have her mic for her, please? Ma'am, you've been on the VRSI safety committee for a long time, so we would like to have your bit on the safety aspect of all these various biosimilars, as well as, so you've seen it all. You've seen problems with Vabysmo, you've seen problems with the brolucizumab, and now with the biosimilars. So can you sum up the safety aspect for us?
So I think very nice talk, Kelvin. As far as the safety is concerned, I think that we all have to be careful when we label a particular drug and make it responsible for the reaction. We have to be very sure whether the injection of the drug, all the precautions were very strictly followed, because sometimes we tend to treat them very casually, that just an injection. So I think that I remember initially when we started reporting it as an adverse event and started sending out an advisory, we realized our mistake. VRSI realized it, that just by one person saying that a reaction has occurred, you really cannot blame it on the drug. And that is the time when we revised our protocol of when we have to send an advisory to the members. And we said that if more than 3 people from 3 different places are going to be reporting an adverse reaction, we are going to hold the drug responsible. So that is number one. So, we have a tendency that on WhatsApp messages, everybody starts pooling and saying, I had this reaction, I had that reaction. I really don't think we need to get carried away by that. The second thing is that we have to also be careful that the ethnicity of the person and how they respond to a particular drug is also very important. Like brolucizumab, I think VRSI published a huge data, and I was one of the authors. We've hardly seen, like, it was just 0.5% that has been reported in the Indian patients. So brolucizumab apparently is not as bad as has been reported.
While it's banned in the NHS, so
Exactly, yeah. But I think in Indian population or Indian patient population, it's done pretty well. And that is why sometimes, like I myself, I've been very careful with brolucizumab. But as I was telling, it's very ironical that all the patients of mine who have been on brolucizumab are all one-eyed PCV patients who have not responded to any other drug. And then I was forced to use brolucizumab because I knew they in any case are going to turn blind. So might as well use a drug and bear with the IOI rather than just leave them untreated. As far as the biosimilars are concerned, like you just mentioned, that we have a biosimilar for Aflibercept. Again, we have to be careful. We just have a 3-month data of that particular drug, and we just start using it right, left, and center because it's more economical. I think we have to give it any new drug. If you remember in the history when Razumab was launched, a number of
had a lot of
reactions
issues
were
with the
reported, yeah,
drug, yes.
and they had to withdraw it. So whenever we have a new drug coming in, we've always faced problems. So just to hold that against the drug, I think like you mentioned, and I was checking up with the company also, they said that all the CGHS patients apparently had an adverse reaction because they were not following the strict cold chain maintenance. So I think in our Indian setup, we have to be very careful that the cold chain, because we have very high temperatures in our
And these
country.
drugs are probably more sensitive to the cold chain as compared to the
Exactly.
other ones. Yeah.
And we have people carrying it in all forms. So is it the drug or is it the loss of the cold chain? I think we really need to check that. Yeah. So that's the safety. I just had one question for Kelvin, that once you have noticed that there is a proper polyp closure on ICG, how do you change your follow-up interval? And has there been any occasion where you had expanded or increased the interval of follow-up and the patient came back with a massive bleed and then you repented? Why did you increase your follow-up?
I think we all have those cases where you either extend it or they decide they don't want to come back and they pitch up in emergency with a big bleed. So if the polyp has closed, I do tend to be a little bit more relaxed. I do tend to increase the interval longer. I use OCTA, I think we discussed this as well, a lot to see if the neovascular network is increasing in vessel density. So not so much the size, but more vessels within the network itself. And that to me is a good indication of whether or not these patients without the presence of polyp can go for a long extension or not. So there's still a little bit of period of monitoring before I really say, okay, let's go big 4-week steps. Let's go to 16 weeks, 20 weeks. In PCV, I tell my patients, even if you're at 20 weeks, I still want to see you at 10 or 12 weeks in between, just for a monitoring visit, just to make sure that you still know that you have a problem. And then, you're not getting a treatment there if you don't need it, but the treatment will be 10 weeks or 12 weeks later. So that's what I tend to do with PCVs. It's It's difficult because patients often become less compliant as they get to longer. Ironically, as they get to longer intervals, they get less compliant because they feel this complacency that things are going well.
Do you have any experience with home monitoring in your tree?
So
Like the Israeli Home City or something like that?
Yeah, so we did a little pilot with this app called All Eye, which looks at essentially they present 3 dots to you, and you move the center dot to try and make it a straight line, so it really detects hyperacuity, they call it. And we did a little pilot over COVID. So when the hospitals were shut and patients couldn't come back, and many of them were going to miss their appointments, we sent out this app to the patients for free. And so they use that to monitor and see whether, if there were some changes, we would call them back as an emergency. And that seemed to actually work out quite well. The trouble is there's a lot of logistics behind running these home monitoring apps. We had the whole reading center essentially having, patients send the results almost daily to see whether they needed to be recalled. That's one. Number two, for large hospital-based practices, having a patient pitch up without an appointment actually is very disruptive.
He goes to the ER, maybe.
Exactly. And then they end up waiting 3-4 hours before they see you. You lose the promise where, something goes wrong, you turn up, you see a doctor, you get a treatment straight. In the ideal world, that's what happens. But in a large hospital-based practice with, I'm sure all of you has huge practices where you really need to stick with your appointments, it's actually extremely disruptive to have these emergency patients come in. And this home app actually increases those numbers by quite a lot. So my fallback is still essentially do a good treat and extend, give them a planned date to come back, right? They know they need to come back in 8 weeks. They know they need to come back in 10 weeks, rather than to say how something's wrong. In the middle of dinner, should I go and see a doctor or not?
Any role of something as basic as an AMSLers?
I mean, that's still good. That's still good. I do teach my patients AMSLers, especially the older patients, 1 eye at a time, and that's still extremely useful. Yeah.
So we have a question from Mumbai. Dr. Prajakta Patel from Mumbai wants to know, what do you think is the reason for increasing activity after switching out of aflibercept? The reason for increasing activity after switching out of aflibercept to anything else, maybe Vabysmo in your case.
So I think that it's again to do with the VEGF the anti-VEGF effects. So remember that aflibercept has the strongest binding affinity of all the anti-VEGF agents we have today. So while you could be having a 2 milligram, but still your binding affinity to the VEGF molecule is very, very high. I have a better explanation if we talked about Vabysmo versus 8 milligram, because really with Vabysmo, you're talking about 6 milligrams of anti-VEGF. And again, if you look at binding affinity of faricimab, it's very similar to ranibizumab, which is probably about 20-50 times less than aflibercept. And then, so if you're talking about 8 milligram, here you're talking about a molecule with very high binding affinity at a much higher concentration. So you're getting a lot of VEGF coverage in the eye. So that's my theory or my hypothesis of why, if you switch out of a stronger binding drug to something that's lesser binding, you may have a second mechanism, but whether or not it's working in these VEGF heavy eyes, nobody knows.
I think that answers Dr. Prajakta's question from Mumbai. Before we have a few more questions, any comments or any questions from the house? Anything, Dr. Aloy or?
Yeah, I'd like to make just one quick comment.
Sir.
That regarding biosimilars, we have been using biosimilars for quite good volume and for a long time. I think by the basic difference is that the generic drug is basically standardized, whereas the biosimilars which we use are bioengineered, and they are going to differ from batch to batch, as they still lack that kind of very kind of standardization. So I think we have to be a little bit careful that from batch to batch, the same biosimilar drug may have a variable kind of an effect. Yeah.
Any other closing comments before we move on to the next speaker? Saxena sir?
And I think it was a good talk and a very nice discussion. So it's been a good session till now. Yeah.
Thank you so much. 2 bits from my side. So as the name suggests, So I think all of us need to remember two things. One is PCV does not need an ICG for diagnosis. If we are more open-minded, if we actually look at the tall peak PEDs, we will pick up PCV much more in our practices. And as Dr. Kelvin has rightly mentioned, and we have enough evidence that if we end up diagnosing PCV, then aflibercept is the molecule of choice all over the world, given, of course, the patient's circumstances. So having said this, we will move on to the next talk by Dr. Manisha ma'am. I'd like to invite her for the talk. Can you help me set up ma'am's talk, please? And I'd like Dr. Alok Maheshwari sir to please come and take over the moderation for ma'am's talk. If we have any more questions, we can always take them towards the end of the session.
A very good evening to all of you. And at the outset, I'd like to thank the Awadh Ophthalmological Society and BEAR for giving me this opportunity to be invited to Lucknow. May I have my presentation, please? I think it's been a wonderful talk by Kelvin, and seeing to his vast experience in managing PCV, I thought that I will mainly focus on how our Indian patients of PCV they apparently do when we try to manage them with anti-VEGFs. Maybe till the time they are setting up my presentation, if anybody has any questions to Dr. Kelvin. So Kelvin, moving on from PCV, what about DME? I mean, do you really advise a loading dose for DME patients as well? A
So-
loading dose?
Yeah, so for DMEs, the way I do a lot of focal laser. So I don't actually load them per se. I do treat them until they're dry. I do a lot of angiography just to see whether there's any leaking microaneurysms, and I do a lot of laser. So I tend to not stick so strictly to this concept of loading doses for my DME patients. Yeah. I'm sure that there's a lot of laser that you guys do here as well. Yeah, yeah. And DME tends to do very well if you do good laser, couple injections, a year or two, you solve the problem for them. That's what I feel.
So maybe we can have a brief discussion regarding DME as well, because I think that's quite a persistent problem in our clinics. So moving on with my talk. I don't know, there's some problem with the presentation. Seems to go. Yeah, yeah. Thanks. So I think as mentioned, as far as PCV is concerned, we see it much more in our Asian population in comparison to the Caucasians. And if we see the data in Indian patients, apparently more than 50% of the patients who are presenting to our clinic, if we really intrigue harder, they are actually the PCV patients, which apparently a few years back we had labeled them as neovascular AMD. We are all aware that PCV is very much a part of the pachychoroid spectrum. And ICG, as mentioned and discussed, still remains the gold standard to diagnose PCV. But in Indian clinics, I think majority of us, we actually don't have ICG. And therefore, we are mainly banking upon the color fundus photography, OCT, OCTA. And of course, these are the three modalities which mainly help us to diagnose PCV quite in a confirmatory way. As far as the hallmark features of PCV on a color fundus photograph is concerned, well, you see over here, these are the subretinal orangish red nodules, which we see on clinical examination. We can see a fibrovascular PED. We can see massive subretinal hemorrhages, peripapillary location, and no large drusens are seen in these eyes. And when you have these five features, you can be quite sure that you are dealing actually with PCV rather than a neovascular AMD. I think Kelvin has elaborated enough that we have features which are very much the hallmark of PCV on OCT, such as a notched PED, a very high peak PED, a hyperreflective ring underneath the PED, and of course the double layer sign. And just to highlight these features again, because these are extremely important when we are trying to diagnose PCV on OCT, you see these large peak PEDs, you see a very distinct sub RPE ring, and you also see these multilobulated PEDs and the notched PEDs. And this classically represents that hyperreflective ring that we see under the PED. And all put together, these features, they have a sensitivity about of 94% when we are trying to diagnose PCV, and they have a specificity of about 93%. My presentation is again not there. I think I'm holding you all back from your dinner. That's why the presentation is not coming up. That's connection. There seems to be a loose connection. Yeah. Yeah. So, as far as the treatment of PCV is concerned, I think we all are aware that we are dealing with the branching vascular network, and we are also dealing with the polyps, and we want to take care of both. So therefore a combination therapy for this particular entity always has worked better. It could be either an anti-VEGF with PDT, which apparently we don't have any longer in our country, and therefore if we are dealing with an extrafoveal pathology, we can also opt for a regular thermal laser along with anti-VEGF. But however, having said that, there is an evidence in various trials that have been published that an anti-VEGF monotherapy, especially with aflibercept, does lead to a polyp closure in quite a significant number of cases. Now, I really wanted to touch upon these two terminologies which we very often use when we are dealing with PCV. One is the polyp inactivation and the other is the polyp regression or the closure. And I think Kelvin also touched upon this. So when we are talking of polyp inactivation, it basically means that the polyp, it stops to leak. There is no fluid, there's no exudation. However, they may activate any time after you have suppressed their activity by using an anti-VEGF very regularly. On the other hand, when we are talking of a polyp closure or a regression, it's basically the closure of the polyp with a lesser chance of reactivation. Now, when I say a lesser chance of reactivation, it really doesn't mean that it has closed for life. And that's the role of having these patients under a very regular follow-up. As far as the polyp inactivation is concerned, it occurs both with laser and anti-VEGF. While when we talk of a polyp closure or a regression, it occurs more by PDT or laser rather than by an anti-VEGF alone. But anti-VEGF alone can also cause when you are very persistent with the therapy. However, both these category of patients, they do need to be kept under a very regular follow-up because they can come back again anytime with a massive subretinal bleed. As far as the APVRS guidelines is concerned, that they have very dogmatically stated that the inactivation of the polypoidal lesions can allow for a good functional outcome with or without the closure of the polyp. And therefore, when we are assessing the activity of the PCV, any of the following features are going to be telling us that there is an activity. One is the new onset of symptoms, which are suggestive of neovascularization, when there's presence of fluid at any level, a hemorrhage, or a hard exudation at the macula. As far as the biomarkers for treatment response in PCV is concerned, they're quite similar to neovascular AMD, and the most important being a drop of the vision, or there is an increase or a presence of a new fluid. Additional prognostic biomarkers of treatment response, of course, have been proposed to be either a polypoidal complete regression, an incomplete regression, and also the status of the polyps closure. Now, I just wanted to briefly introduce this, that we are always under the belief that the PCV is always having a thick choroid. And I was just discussing it with Kelvin that there is a concept that you may not have a thick choroid always associated with PCV, and the response to the anti-VEGF also depends upon what kind of a thickness that you are dealing with in your patients of PCV. So please don't have this concept that if you don't see pachychoroid, you are not dealing with PCV. So there is a group of patients, though very less, where you can have PCV and it may be associated with a thin choroid. So PCV can have a variable choroidal thickness, and the clinical features in response to anti-VEGF treatment may actually correlate to a subfoveal choroidal thickness. So younger patients with PCV with pachychoroid, they have less AMD features. They have larger lesion size with more prominent polypoidal lesions and more choroidal vascular hyperpermeability on ICG. And they tend to show lesser response to anti-VEGF monotherapy and a better response to combination therapy. It could be PDT plus anti-VEGF or a thermal laser with anti-VEGF. However, on the other side, the older patients with PCV with thin choroid, they have more AMD features, they have smaller lesion size with less prominent polypoidal lesions, and they tend to show more greater response to anti-VEGF monotherapy. So subfoveal choroidal thickness is an important predictor of response to treatment and to the final visual outcomes. There is a study by the Singapore National Eye Center, and which has compared aflibercept 2 mg with and without a reduced fluence PDT in PCV patients. And they basically randomized these patients into two groups, where one patient had undergone aflibercept with PDT, and the other one, they were just treated with aflibercept monotherapy. And when they assessed what were the outcomes at the end of 1 year, the visual recovery was hardly any different between the two groups. The mean change in the subfoveal thickness was hardly any different between the two groups. But the proportion of patients who underwent a polyp closure was significantly higher in the patients who had undergone a reduced fluence PDT in comparison to the group which was treated only with the monotherapy. Now, this is one of my patients. This is a young male patient who presented with this massive bleed in the macular area. The vision was as low as 660, less than N36 in the left eye. You see, he has a massive bleed under the retina, and I opted to go ahead and give a tissue plasminogen activator injection along with C3F8 gas in the left eye. And this is the timeline of the patient after he underwent the injection. You see that this was followed by the loading dose of 3 injections of 2 milligrams of Eylea. And you see that the patient gradually started doing well, and this three injections of Eylea were then followed by a full fluence PDT. In my case, the patient recovered a vision of 624 N24. You see that there is a recurrence of a mild fluid which is secondary to the PDT in this particular patient. This was followed by another injection of Eylea, and the patient did recover a good vision of 69 N8. He was advised treat and extend, and he took it for 6 months. The problem with the patients is that once they recover a good vision, they are very hesitant to undergo an injection when they see that the lesion is totally dry. And this patient apparently was lost to follow up. He came back to me 4 years later in 2023 with again a massive bleed. You see, he has really got a activation of the pathology again in the left eye. And this time again, we started treating him. We gave him 1 dose of Eylea, again followed by TPA and C3F8. And this was again followed by a loading dose of Eylea. He did recover a vision of 624 N24, and we put him on a treat and extend with Eylea for 1 year. And at the end of 1 year, he recovered a vision of 612 N12. This particular case basically highlights that whenever these patients have a recurrence, probably the result cannot be as good as what has happened in the first time, and thus the relevance of keeping these patients on a regular follow up and at times also on a treat and extend therapy for a long duration. Now, as far as how do we extend these patients with PCV, well, the protocol remains quite same as treating a patient with neovascular AMD. We do have this trial, the Altair study, which had similar patients who had PCV and who did not have PCV, and they were basically divided into two groups. And what was good was that more than half of the PCV cases, they could achieve an interval of at least 3 months, and more than 40% could achieve an interval of 4 months between the subsequent injections. There's another study by Maruko et al., and they had apparently a group of 97 eyes, a combination of PCV, neovascular AMD, and RAP. And all these patients, they underwent a loading dose of 3 aflibercept injections followed by treat and extend. And then once these patients were evaluated at the end of 2 years, there was hardly any difference in the way the patients with PCV and neovascular AMD, the way they had responded to aflibercept. So what I basically want to highlight is that when we are treating these patients, when we are treating neovascular AMD and PCV, they do respond in a similar way when we are treating them with aflibercept. I think Kelvin has already touched upon this particular slide, where we see that the complete polyp regression also has been observed across various clinical trials and real world case series with aflibercept in PCV. So there is an element of patients where with just an aflibercept monotherapy, we can get a polyp closure without really any additional PDT or a laser therapy. This is another patient. I now have about a 5 year follow up of this patient. She had a bilateral PCV in both the eyes. She was having a good vision. If you see, the macula looks pretty good, but she had an extrafoveal large PED. And we gave her a loading dose of Eylea in both the eyes. The right eye was doing pretty well, but she was lost to follow up for 1 year. And then again, she came back with a recurrence of the disease in the left eye, where you see this large PD with the subfoveal fluid that has developed. So this patient again undergoes multiple Eylea injections. Both eyes were found to be extremely stable. We did not have PDT, and therefore, once I was dealing with an extra foveal lesion, I had TTT in my clinic, so I actually took a chance and I treated this patient with TTT, and the patient had a very good response in the left eye, where you see that there's a complete regression of the pigment epithelial detachment, and the patient was doing extremely well. Again, the patient, as I mentioned, it's very difficult for these patients to keep them on a very long term treat and extend, because once they recover a good vision, they feel that you're unnecessarily treating them with more and more injections. So, this patient did continue with me on a treat and extend for about 5 to 6 months. Again, she was lost to follow up, and she keeps coming back to me here and then. Sometimes she comes back with the right eye. She's had a fresh bleed, and now I just treat her with PRN dosing of aflibercept. You see, now she's had a bleed in the left eye. And so this keeps going on and on. But what is good is that now she's developed a cataract in both the eyes. That is the cause of the drop of the vision. But otherwise, the retina looks pretty stable now. And I just keep a tight check and a regular follow up and just offer her a PRN dosing of the aflibercept. This is an interesting article, and which tells us that how these patients fare long term. And I think what is important for PCV patients is they have to have a regular follow up, despite they looking very stable when you start seeing them in your clinic. There was another study published by Shankar Netralaya, which has told us that about 70% of the patients, they do extremely well when they've had a recurrence of the PCV lesions. They respond extremely well to an aflibercept monotherapy, and that is something very encouraging. Uh, this is an interesting survey which has been done with the various VRSI members, and it was a study a survey published by the VRSI study group, and just a few questions I have picked up. And this survey included a question that if photodynamic therapy is not planned, then is there a role of ICG in PCV? Because we used to basically do ICG when we wanted to plan PDT, and about 50% felt that still there is a role of ICG despite you not planning a laser therapy, while 50% felt that ICG is really not required. And there was a question that what is your preferred anti-VEGF therapy when you are initiating treatment for PCV? And about 63% of the members, they felt that aflibercept is the first choice when you are treating PCV, and the second choice, of course, is brolucizumab. Now, having mentioned that, just a few minutes back, Dr. Samarth asked me regarding the safety profile. As far as the brolucizumab is concerned, that despite we saying that it's just 0.5%, if I have my relative having a problem, I think I will hold back for using brolucizumab for treatment naive patients, because even if the risk is low, but you do have very severe reactions like a CRAO or a vasculitis happening, and therefore you are a little skeptical in using brolucizumab in the treatment naive patients, and probably it remains your second choice. The other question was that what treatment regimen do you follow for treating cases of PCV? And majority of the members, they felt that they prefer doing a loading dose followed by PRN, but quite a few of us now believe that a loading dose followed by treat and extend is something of our choice when we are treating PCV patients. And another, there was a choice that if which anti-VEGF agent do you consider switching if a patient is not responding to aflibercept after 3 monthly injections, and majority, about 63% of the members, felt that switching to brolucizumab is a good choice, a logical choice, till we don't have aflibercept 8 mg in our armamentarium. This was a study which was published again by us from the VRSI study group, where, as I mentioned, that brolucizumab was found to be pretty safe. But yes, there is a small element of risk of having very severe adverse reactions, if at all there is one. So, after having reviewed the various RCTs and real world evidences and various case series published, beyond doubt, the PCV can be treated similarly to those patients who are having wet AMD using a proactive aflibercept monotherapy. And I'll just summarize my talk by saying that fundus photo and OCT, they are adequate to diagnose PCV, and ICG is really not mandatory. A combination therapy works the best for PCV management, and anti-VEGF with PDT still remains the treatment of choice. Monotherapy anti-VEGF therapy may work as well and can cause a polyp closure in a significant number of patients. Aflibercept monotherapy may score over other anti-VEGFs which are available for PCV management. And as mentioned by Kelvin, the reason for that is that it has a highest binding capacity, and even the durability is quite high in comparison to the other anti-VEGFs which are available. So aflibercept surely scores much higher in comparison to the other anti-VEGFs when we are managing patients of PCV. So thank you so much for your patient listening. I'll be happy to take up any questions.
Thank you, ma'am.
Very nicely elaborated and very well, nice talk. So any questions from the panelist and the audience? So, ma'am, I just want to know what is the end stage for your aflibercept injections treatment? How we decide when now we should stop?
So I think the end of any treatment would be like, if ideal situation would be when I am getting a polyp closure. I think, and that is something which we can see on doing an ICG. But sometimes that is not always possible, because here, as I was mentioning, the patient is paying out of his own pocket. So I would, if I was to monitor my patients on OCT, it would be inactivation. And when I say inactivation, when I don't see any kind of a fluid, I don't see any subretinal fluid. I see that it's lying like a very mundane kind of a pathology over there. Also, I have started doing OCTA, which tells me now that there are only mature vessels. There is a good regression of the BVN that I am seeing. I think that is the time when I'm going to hold back my therapy. However, having said that, I'm going to keep the patient on a very regular follow-up.
So what is your schedule of the follow-up? And do you do the this imaging in every follow-up?
Yes, I would surely go ahead and do non-invasive imaging is not really a big deal. So whenever I would follow up these patients initially, at least every month for the coming 6 months, maybe. And every time they are coming for a follow-up, I think I would surely go ahead and do an OCT and an Optimus.
So with these various findings on the OCT, can we consider the OCT as a new gold standard in comparison to the ICG?
I would not say that it is going to be the new gold standard, but yes, to a very large extent, I'm not going to feel handicapped if I don't have ICG. That still remains the gold standard for PCV. But yes, if I'm not having ICG, I would say I'm quite comfortable in managing PCV patients with OCT and OCTA.
So, ma'am, in your setup, do you feel so that this PDT along with the aflibercept is much more good in comparison to the only monotherapy?
I would say that because surely when we are giving a combination therapy of PDT and aflibercept, the number of injections required do reduce. However, if I'm not having PDT, I'm going to be more persistent with my aflibercept monotherapy. Of course, the number of injections are going to go up.
So, ma'am, any role of the thermal laser and which type of cases?
So I shared one case. I am very fond of doing thermal laser. So that is one time when I do need an ICG to locate these lesions properly. And if they are extrafoveal, I do not hesitate to go ahead and do a thermal laser. The other entity, which I'm sure a lot of you have faced, is the PEHCR, the peripheral PCV that we tell. I go ahead, I do a regular thermal laser for those patients. I've also gone ahead and done a cryotherapy for those patients, and they do extremely well. So for me, that would be I'm really in a lookout that if I get a lesion where I can add the laser, it really helps me and makes me feel more secure that the disease is not going to come
And
back.
the recurrence rate is also
Yes.
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 If there is a breakthrough bleeding, and is there any role of the anti-VEGF drugs pre or post-operative vitrectomy? Or if yes, then which agent would you like to prefer as an
So
anti-VEGF?
you're saying that if there's a breakthrough
Breakthrough
bleed and
bleeding
you've
and
done an I mean, you've done a vitrectomy.
vitrectomy.
So, we need to understand that the patients have come with a breakthrough bleed. Of course, sometimes, I don't know, Kelvin can correct me. A breakthrough bleed itself means that there is a regression of the disease. But that doesn't mean that you leave these patients untreated. After I've done a vitrectomy, I will follow the same protocol, keep monitoring these patients and treat them with aflibercept the way I do without the breakthrough bleed.
Right. But
Kelvin, do you want to add something to that?
Yeah, no, I agree. If in a lot of cases with the breakthrough beat, I feel like the lesions bled out and
Yes.
it becomes very quiet after that.
Right.
So I have a question about your TPA and your displacement. Do you do TPA for all the cases in general, or is
No.
there criteria?
So only when I'm seeing a massive bleed, which is in the subfoveal area, that is the time I would surely go in for a TPA with a gas bubble. Because I've read through a lot of articles where they've just treated them with an anti-VEGF monotherapy, but in my hands, I've always felt that the visual recovery is much faster. Also, my imaging modality, like when I'm doing an ICG, if I've been able to displace the blood much faster, I am able to image the polypoidal lesions much earlier, and then I can plan my treatment much faster.
So the trouble I have in Singapore is that TPA is expensive. So I end up doing just the gas bubble displacement without the TPA, and that seems to work quite well for me. So I'm just curious, at which point would you even consider just the bubble alone, or it's always a bubble with TPA?
I would always do a bubble with TPA.
So,
Of course, it does depend
yeah.
upon the affordability of the patient, but I think it's costing now about we do have some company which has come up, which is quite reasonable. It's about 16,000 rupees.
So we have to break a full vial of TPA,
Yes, you have to.
which is
Yeah.
very
Yeah.
So thank you.
Ma'am, which gas would you prefer for that tamponade?
I give a 100% C3 of it.
And do you use this aflibercept along with the TPA?
No. So what I do is that I initially, because the volume you've already injected two things in the eye, So I initially give just a TP and a C3F8. I'll give a positioning to the patient after a week, maybe, because it's just a small bubble that you've injected about zero point 0.3 to zero point 0.4 ml. After about a week or maybe 2 weeks, I go in again and give the aflibercept.
Okay. Ma'am, what's your cutoff for the number of days when a patient shows up after a bleed? How long would you, I mean, how old a bleed would you not go in for surgery?
You do get these patients who have a very altered kind of a blood, a whitish, yellowish looking. I don't think that's going to get displaced. So there, I'll just stick to a monotherapy of the anti-VEGF.
So any ballpark figure in terms of number of days?
No, not really.
Not really.
Not really. I feel that you have to be pretty aggressive. If more time has lapsed, when they present to you and you do still see a red blood sitting there, I really don't tax my mind how much is sub RP, how much is subretinal. If the patient is okay, he understands his prognosis, I would give the best shot and give a TP and a C3F8.
So finally, in Indian scenario, how you counsel your patient for so many intravitreal injections, and in spite of he got some improvement, and in spite of that, you ask them to come and for follow up and for imaging.
So I think I must mention this, that treat and extend is something we all love, because we have these patients coming back with fresh bleeds, as I showed, after 4 years also. But if you were to see from a patient's perspective, you have gained a 6/9 vision. You keep showing them OCTs and they say, अब तो डॉक्टर साहब सब कुछ dry लग रहा है, तब भी आप कह रहे हो injection and all. So earlier on, it used to be pretty difficult. But from the time Bayer has come out with the patient support program, I think the injections have become far more affordable, and it has become more easier to keep the patients compliant when you are advising them a treat and extend. But yes, I think all of us face this problem where the patients are lost to follow up and they do come back. And sometimes you are forced to put them on a regular follow up and just stick on to a PRN dosing. I mean, but yes, for one-eyed patients, it's easier to counsel them, easier to keep them on a treat and extend, because they do realize that when they come back with a recurrence, they never recover back the same vision. So I think they are more open to the idea of a treat and extend rather than the patients who are seeing with both their eyes.
Ma'am, we have 2 questions from the house.
I think Dr. Pooja is
Hello.
here.
Good evening.
Dr.
Good to
Aloy
see
has
you,
a question.
Pooja. Yeah.
Good evening, ma'am. Ma'am, very nice presentation. As a comprehensive ophthalmologist, my question is, how will you manage a case of PCV with the cataract? That is significant cataract.
So, if your imaging modality through that cataract is telling you that it is an active lesion, I am not going to operate. I am going to first treat the patient with a loading dose of my aflibercept. If I can do the OCT, I can monitor. I'll just hold back, because there have been studies published where after the cataract there has been a progression of the PCV lesions. So till I don't find that there has been a good regression of the disease, I will not go ahead and do the cataract. Having said that, there can be another situation where you are just seeing, but you are not able to monitor the patient with any imaging modality.
Yes, sir.
I would probably then do a combined procedure where I'll do a cataract along with an anti-VEGF, aflibercept, and then keep the patient under a regular follow-up and treat the way you do any other patient.
Would we like to give the anti-VEGF 1 week before, or
No, simultaneously I can do
simultaneously
that,
we
yes.
can?
Because 1 week before doesn't make any sense. You're not expecting any bleed to happen during the surgery.
Okay.
I don't know what protocol, Kelvin, you are following.
So I actually, I mean, if it's a visually significant cataract, I will go in and do both together. I mean, I agree that keeping it stable for some time, and that would be the best case scenario, and then we can plan for a cataract with a combined aflibercept in like 8 weeks or whatever.
Right.
But if visually significant, one eye is lost to a scar. I mean, I'm just thinking about a patient I just did, literally one eye scar, the other eye visually significant cataract, and a PCV. I went in, I did the cataract surgery, I did the aflibercept, and I give it a little bit of steroid,
Right.
just to keep things under control from an inflammation point of view as well.
Dr. Kevin, I wanted to know if you had some more side effect with PDT than with monotherapy,
With
mono injections.
more side effects with PDT versus
PCV.
for PCV. The biggest side effect I get with PDT is probably number one, after a week, you get this dimming of the vision because there is some choriocapillaris shut down, and patients will say that this round patch that they don't see very well. It tends to settle down very quickly. And then the second one is rips. I do tend to see some rips in the big PED, so those I'd be a bit more careful. And they tend to happen in older patients and patients with a thinner choroid. So the thin choroid patients with PDT, I'm also a little bit more cautious. Yeah.
Dr. Kelvin, have you also seen rips with Vabysmo, faricimab? We do see a couple
Yes.
of rips with Vabysmo because
Yeah.
of the drastic effect it has on the.
Yes, I think that the bias here is that I tend to probably treat Vabysmo in patients with non-PCV. So the RP is a little bit weaker, it's grottier, the patients are older. So then I think that puts them at higher risk of having a rip. So that
One small thing. Manisha, do you have access to PDT at this point of time?
PDT?
PDT.
No.
No.
So that's the question, the
The diet
pertinent
not
thing.
there
We
in
are all talking of PDT and combo therapy, but we don't have PDT in India.
No, so
It's
that's
really
what,
available.
so that's exactly what we are trying to highlight, that despite we are not having PDT, monotherapy also can cause a polyp closure. However, you have to be very persistent with the therapy. It is not going to be working like, that you have given a few injections and you're expecting the disease will keep coming back. And that is why I just shared the studies also where they have got a polyp closure also with an aflibercept monotherapy. And just to share the information that Arvind Group is already, they have come up with vertiporfin, and now they're trying to just work on the laser also for PDT. So I think in the coming few months we should be quite hopeful to be having PDT.
Yes.
But we should also be open to the idea of we could really be hunting for the extrafoveal lesions, which can be targeted with a thermal laser. And that is why I also shared my patient where I actually went ahead and did a TTT also, which worked pretty well for the extrafoveal lesion and caused the regression of the PD.
Yeah. Second thing about the rips. So in a reduced fluence PDT, the incidence of rips is relatively lesser. Number two, the rips are maximum seen with brodalumab as compared to the other molecules.
I would agree with that.
Yeah, and followed by faricimab, followed by aflibercept.
Yes.
And the minimal with ranibizumab.
I would agree with that because brolucizumab has the maximum drying effect. So there's a sudden shrinkage which happens with large PEDs. I would agree with that. Yeah.
So any final comment with Dr. Sir?
Well, I feel in this session, aflibercept still remains the best option for PCV. Regarding other drugs like faricimab or so, I think it may hold well where there is a big element of inflammation. But here, with the PCV mechanism happening in the eye, I think aflibercept still remains the best choice, and time will tell for our Indian scenario how the 8 milligram of the drug will work out. Yeah.
Thank you.
Thank you, ma'am. And I would like to invite Dr. Alaya Majumdar for some interesting cases.
Yep. Good evening. I hope I'll hold you back a little more from your supper
10
or
minutes,
dinner. I would
10
like
minutes
to say.
exactly is what you have.
So thank you so much, about the Ophthalmological Society and Bayer, for having me here. I'll be sharing some of my cases. However, all of these cases with all its variances have been already shared by Dr. Kelvin and Manisha. So that's my first case, non-diabetic, non-hypertensive, and you can see a massive subretinal hemorrhage with a hemorrhagic PED. So what I preferred at that point of time to go ahead directly with an aflibercept with a C3F8 gas bubble. And 3 days later, the vision improved to 624 from the prior vision of 3/16. So after 20 days, you see a nice flattening of the hemorrhagic PED. Vision has improved to 612. IOP is nice, Minimal SRF is there, some HRF in the outer retina, and regressing foveal and macular PED. Now, the concept of HRF is very interesting. What I usually differentiate when I have a PCV patient or a type 1 CNVM, if I have an HRF that is spread all over the retina, both in the inner layers and the outer layers, my drug of choice is usually faricimab. But if it's more on the outer layers, I prefer aflibercept. So in this, as you see, the here, so okay, is there a pointer here? So if you see, you have got much more hyperreflective dots in the outer layer of the retina. So aflibercept is known to resolve these HRFs much better as compared to faricimab, which actually resolves the inner retinal HRF better. That's the octa, and you see not much of the features because of the hemorrhage out there. So the patient now travels to Delhi, and this was a OCT done at Delhi about a month from there, and has come back to me 6 weeks post aflibercept with C3FH. Now that's a montage in which the vision is well maintained. You see a peripheral subretinal hemorrhage, which is still there, which is clearing off. Fovea has cleared off, and so we repeated aflibercept 2 milligrams. So that's 1 month post second dose. You see a nice resolved foveal hemorrhage. The vision has improved to 6/9 part. Thank you. And that's the octa. But we do have some peripheral subretinal hemorrhages which are now resolving, and some peripheral PEDs. So this is again, the next visit is at 4th of September. And that's the octa at this point of time. You see some deviant out there that's now resolving in there. And these are the things, but there was no IRF, no SRF, no HRF. So I decided to wait. That's the October, November. And when we had 3 months of no activity, I decided to call the patient after 3 months. So that's the 1st of February octa. You see a nice clean thing, but we see a small PED coming in here. So I gave aflibercept once more in February, and it is now resolving. That's about a month from the last aflibercept, and then I again waited and watched. But again, on 4th of June, there's a small localized serous PED that's developing. So it's the case of recurrences. It's coming back again and again, as in cases of PED and PCVs. So octa showed no specific developments, but we have a small PED, but no metamorphopsia, hardly. Vision 6/9, we again decided to observe the present. But now the patient comes with a progressive increase in PED. Now we see the PED has not increased. Small ERM coming with little macular traction that's happening. So now this time the patient has come from Delhi. He shuttles between Lucknow and Delhi. There he had shown somewhere and was advised faricimab. He's a CGHS beneficiary. So faricimab was already issued to him, and an advisory of giving faricimab was with him, and he insisted on getting that injection done. So we gave it, and that's in November. A little change, hardly any change, as we see in the size of the PED. However, faricimab was again repeated, and that's what patient again comes back in April. So 2 doses of faricimab which we had. The last was given in November, and that's what the patient comes on in April. A hemorrhagic PED out there. Vision had dropped down to 624, and with a significant metamorphosis. So down here, I decided to give aflibercept in April, and that's the resolution. It has the regression noted, and the vision has again improved back to 6/9 from the peak which we had. It has gone back, it's going back. So we repeated aflibercept in this case. So the next case is another case of relapses and remissions that we see as a classical feature in the PCVs. A non-diabetic, non-hypertensive, FFA was done, OCT was done, all the thing was done, and given ranibizumab. At that point of time, ranibizumab was the predominant molecule with us, and then came corona. So the patient was lost to follow-up and returned quite some time back, about 1.5 years back. Here you see uh, a classical smokestack appearance, multiple points of leakages, a CSCR, and you can see all three varieties of CSCR patterns. You've got an ink blot, you have got a smokestack, and here you have got some RP defects. So that's the presentation initially in 2019, and that's how we presented in 2021. Kept under observation. Now we see here, we have a small SRF, not much anything else. We can't see even a membrane, probably a small wrap in here developing with a PED and some SRF out here. So that was the condition, and the patient was given another ranibizumab, and the patient was stable till 25/12/21, and the vision 6/9, 5/60. But then CME, PED, and suspected reactivation was noted. So that was the condition. And now the patient again presents with a full-blown reactivation in December 21. So we now have all the features of the reactivation. We have PED and the IRFs. So now we gave aflibercept. We have got a resolution, and this is 1 month from the first dose of aflibercept. That's the second dose given. We see further resolution. That's the third dose, and after 3 months of the after 2 months of the third dose, we see quite a good resolution and a resolving PED. A minimal IRF is there, some reflective dot ecos. Now here, this is again 2 months down the line, pretty stable, flattening PED. So we repeated aflibercept in here because we had some IRF in here, and that also resolved well. Vision was stable at 6/9. This is 2022 October. And now patient was lost to follow-up, comes back in March 24 with the right eye stable, left eye with a recurrence and an IRF, vision 6/24. So now again, we gave aflibercept in March, and you can see the resolution again happening. And the BVN regressed. Here we have the BVN, the pre-injection BVN, which is showing the regression. So now the case 3, a 73-year-old non-diabetic, hypertensive, hypothyroid. That's the presentation. All of our cases will be having long-term follow-ups. So 2022 patient, we have pachychoroid changes and with a cataract, with some PED out there. Some old scarring in the RP and paramacular flat PEDs were there. And in the other eye, here we have got a full-blown CNVM with subretinal hemorrhage. So aflibercept 2 milligrams were given on 29/1 and 10/3, and that's the resolution on 31/3. You see the IRF going down. You see a knuckle PED here, which shows the polyp. And aflibercept was repeated. The third dose was repeated, and we have a further resolution. We see a very clear knuckle PED of the polyp. Aflibercept was again repeated, and see the PED settling down. The PED settling down, getting resolved. So as Dr. Manisha and Dr. Kelvin showed, that this regular dosing of aflibercept can lead to a very nice resolution of the PED, and that is the end point of that PED causing that CNVM problem. Because this is a recurring problem. You can have a PED here and a polyp here, creating a CNVM here. Tomorrow it can happen somewhere else. The day after, it will happen somewhere else. So the patient has to be under a regular follow-up. So this patient was advised aflibercept at this point of time, but he refused and lost to follow-up. Coming back after about 5 months with a recurrence, and aflibercept was repeated, then again lost to follow-up. Again coming after about 8 months, 9 months. Now we have an active CNVM in both eyes. So this has worsened down, and this is, which was nice and flat PED, has now come up with a CNVM, active CNVM. Vision in the right eye is 2200 and the left eye is FCF. So both eye aflibercept were given. And that's the resolution after about 50 days of aflibercept in both eyes. We see a nice resolution. This is again next month after the second dose. The resolution is beautiful. The vision in the right eye improved, in fact, to 6/6. In the left eye to 5/60 from counting fingers. We have a complete resolution of the intraretinal fluid, regression of SHREM and the signs of activity. And after 2 months, we saw the patient. There is a little serious PED that's coming on in here. Initially, we remember this was going bad, but now this is also following the cue. So that was a very important telltale thing, because if you have it in one eye, the other eye is going to follow. If not today, then tomorrow. So beware. Do not let these patients out of follow-up. So aflibercept was given in both eyes. And that is 2024. We see a nice regression after a month. This patient comes, gets a problem, comes to us, gets injected, goes away. So that's a persistent thing, which is classical of all the patients, and we have to bear with it. So now the patient was pretty stable, no sign of activity, so refused aflibercept, went back, and again comes back after 2 months. So here we have again a sign of activity, and we give aflibercept, goes back, comes back in 3 months, and this has continued. Now here we did an octa, we find a nice clean BVN in this patient. And the other eye, the SHREM was pretty stable. The patient in August was seen after a month of aflibercept, was pretty stable, was after 3 post anti-VEGF monthly visits, and so was called after 3 months. But this is again missed, lost to follow-up, comes back after 11 months with again a finger counting vision, this time in the right eye and 1/60 in the left eye. So again injected. We have the octa showing the active BVNs in both eyes. And this is 6-week